Now we are going to discuss the head injury part of trauma and general surgery. So in head injury, the symptoms of the head injury the patient presents with the symptoms of the raised intracranial pressure. That is, earliest symptom, it is altered sensorium, vomitings, headache, seizures, ENT bleeding or the discharge. If patients presents with the raccoon eye or the panda sign, that is presence of the black eye with subconjunctival hemorrhage, it indicates that two condition, either it may be due to the local injury to the orbit or it may be an injury to the anterior cranial fossa. So if there is any anterior cranial fossa injury, patient may also present with a CSF rhinorrhea. This CSF rhinorrhea is also seen in the middle cranial fossa injury. And second sign, it is a battle sign, that is bluish discoloration of the mastoid. It occurs due to the middle cranial fossa fracture. In battle sign, also the patient presents with the CSF otorrhea, rhinorrhea and hemotympanum also. So if patient presents with the head injury, we have to grade the severity of head injury based on the GCS, Glasgow Coma Scale. So we have this revised the scale. Previously, if anything which is non-testable, we used to give the score as a 1 and write it as a non-testable. But now we are not giving any of the score of 1. We just labeling it as a non-testable, and reason for the non-testable. For example, if you can't record the verbal response of the patient due to the intubation, so we have to note it as a non-intubation and verbal response is not testable. So what is the revised scale? So we have the 3 main parameters we need to check. We have to check the eyes opening and verbal response and motor response. So eyes opening, if the patient opens the eyes spontaneously, we give the score as a 4, and opens on sounds 3, and opening of eyes on pressure, it is of 2, and none, score is given as a 1, and if any non-testable, note it as an NT. And verbal response, if patient is oriented, give score 5, if confused, give 4 as a score, and speaking words, give score 3, and speaking sounds, produces the sounds only, give score as a 2, and no response, none, it is 1. If it is non-testable, note it as a non-testable. Next, motor response. So if patient obeying the commands, give scores as a 6. Patient only localizing, give score as a 5, and normal flexion withdrawal, give score 4. Abnormal flexion, it is give score 3. Extension 2, and none means 1. This is according to the response recorded, we have to give the score, and based on the GCS score, we grade the severity of head injury into mild head injury, moderate and severe head injury. So mild head injury, it is if score is between 13 to 15, if moderate, if score is between 9 to 12, and severe if score is less than or equal to 8. We also label it as a coma. So in coma, the next step should be of if a GCS is less than or equal to 8, next step should be of intubation. We have to intubate the patient, whether he is breathing spontaneously or not. Irrespective of that, we have to intubate the patient. And next, so for the moderate and severe head injury, we have to do the investigation of choice, that is the NCCT. In mild head injury, the NCCT is done only when if the GCS fails to return to normal within 2 hours, if a vomiting of more than 2 episodes are present, there is a base of skull fractures are present, and open or depress the skull fracture, if the patient age is more than 65 years, or patient is on a blood thinners, loss of consciousness is more than 5 minutes, and retrograde amnesia of more than 30 minutes, and dangerous mechanism of injury if present. In this situation only we have to do the NCCT. So most common head injury is contusion over the SDH. So SDH, it is nothing but occurs due to the injury to the bridging veins or the dural venous sinuses, dural sinuses. SDH, it is acute or chronic. Acute if it presents within 3 days of trauma, chronic if presents after 3 weeks of trauma. So in chronic condition, commonly seen in the elderly who present suddenly with a sudden onset of LOC, headache, or the sensorium, the history of trauma is not provided. So NCCT, if we do the NCCT, we see the concave or convex or the crescent shape opacity is present. In boxes, SDH is more common over the EDH. SDH is very dangerous, more dangerous. Next type of hemorrhage is the EDH. In EDH occurs due to the injury to the middle meningeal artery, which is an anterior branch. Most common site it is a temporoparietal region just above the pterion. And this in EDH we have this lucid interval, which is a loss of consciousness and regain, and the loss of consciousness is present. So between the two periods of the LOC, we have the regain of consciousness is present. If we do the NCCT, we can get the biconvex or the lenticular shape opacity is same. This EDH, extradural hemorrhage, so outside durana, so never crosses the suture lines, therefore it edges are pinpointed. So this EDH is present with the lateralizing side, that is pupillar dilatation is present on the same side and weakness of body on the opposite side. If a patient previously we don't have this NCCT previously in old age, what they do is if the patient presents with the ipsilateral pupillar dilatation with contralateral hemiparesis, we have to they used to take the people immediately to the OT. Burr hole is done on the side of the pupillar dilatation, that's just above the pterion. Even the general surgeon can do this. Earlierly, if the patient presents with the bilateral pupillar dilatation with quadriparesis, we have to look which pupil dilated first. So if on which side the pupil dilatation occurs first, on that side we have to make a burr hole on that side. If pupillar dilatation is not known, they used to directly drill a burr hole on the left temporal side, then the right temporal burr hole is done. So as in the olden days, the NCCT is not available, therefore they used to do in this way. But now the NCCT is present, so do the NCCT. If the blood is present, do the craniotomy. The craniotomy is preferred over the burr hole. Craniotomy is nothing but opening of the skull and removal of the clotted blood and closing of it. Next injury, it is an SH, that is subarachnoid hemorrhage. The most common causes of SH, it is trauma, and most common causes of spontaneous SH, it is a rupture of barrier aneurysm. And diffuse axonal injury, other type of injury is diffuse axonal injury, which is a worst scenario. It is a shearing tear, that is accelerated dislocated injury, which is between the grey and white matter. The blood is present in the basal ganglia or the corpus callosum. If we do the NCCT, we get the collapsed basal systems with multiple contusions are present. For the investigation of choice is an MRI. And what is the management of head injury? So our primary, so this SDH, EDH, diffuse axonal injury, everything, or the primary brain injury. So because of this primary brain injury, the ischemia which is produced by them will cause as a secondary brain injury. Our main goal is to prevent the secondary brain injury. So how we are prevented? We have to maintain the cerebral perfusion pressure. So cerebral perfusion pressure equal to mean arterial pressure minus intracranial pressure. Because of the primary brain damage, the intracranial pressure is very high. So in order to put this cerebral perfusion pressure in normal limits, we have the two options. Either we have to increase the mean arterial pressure or decreases the intracranial pressure. But in head injury, our body has a special mechanism, that is a Cushing reflex. So on the head injury, the mean arterial pressure gradually increases. Because of Cushing reflex, hypertension and bradycardia is produced and mean arterial pressure is very high. So we no need to increase the mean arterial pressure. We have the second option, that is reducing the intracranial pressure. Next, if by chance any patients of the head injury presents with the hypotension, there are only two reasons of presence for that. One, it may be due to the brainstem injury, and second, it may be bleeding somewhere else. So in a head injury, we have only single management, that is we have to lower the intracranial pressure. We have two options of medical and also the surgical means. firstly we have to try the medical management, that is give the 100% of oxygen with initial hyperventilation and elevate the head end of the bed. And third, it is maintain the normal volemia and hypertonic saline, osmotic diuretic, that is IV mannitol, neuromuscular blockade, hypothermia, benzodiazepines and barbiturates. So if a medical management is not sufficient, after osmotic diuretic, that is after giving the IV mannitol, we add the surgical means, and then by continuing the remaining medical management. So what are the surgical options we have? Craniotomy or the burr hole or the ventriculostomy. These surgical measures are done if any of three conditions are present, that is if there is midline shift of ventricles are present more than 5 mm, if volume of blood is more than 30 ml and intracranial pressure is more than 20 Hg. In this situation we have to do we should add the surgery. And factors which are aggravating secondary brain injuries are the first, it is the hypotension, hypoxia, hyperthermia, hyperglycemia, hypercapnia and seizures. Next, post-traumatic seizures. What are the post-traumatic seizures? We grouped into immediate, early and late. Immediate, if it occurs within 1 week of trauma, it is also called as post-traumatic epilepsy. Early, if it occurs within 1 month of trauma. Late, any time after many months or years of trauma, it is termed as a post-traumatic seizures. Prophylaxis for this, we have to give the phenytoin for 7 days in the patients of the head injury. So how to know the prognosis of head injury? By calculating the score, that is GCS minus pupillary reaction. Pupillary reaction reactivity score. With pupillary reactivity score of 0 if a bilateral pupils are reactive to the light, and score of 1 if it is unilateral pupil is not reactive to the light, and a score of 2 if bilateral pupil is not reactive to the light.